Hello, everyone, and welcome to the 15th episode of the Atlas Society Asks. Can you believe it? For those who have been joining us every week for the past few months, you know who I am, Jennifer Grossman, CEO of the Atlas Society, and I'm introducing myself for those who are new because our online audience has been growing by leaps and bounds. So before I even introduce my friend, Dr. Jeffrey Singer, I want to remind you guys joining us on Zoom, type away, type those little questions into that chat box, and all of you guys on Facebook, ask whatever you want. Just try to keep them short if you can, so that we can get to as many of them as possible. So Dr. Jeffrey Singer is a general surgeon in private practice. He's been practicing for nearly 40 years. He's also a senior fellow at the CATO Institute, my old stomping ground, and he serves as a visiting fellow at the Goldwater Institute in Phoenix, Arizona. I'll also mention that he happens to be almost a 30-year donor at the Atlas Society, which is pretty incredible. So maybe we'll get to his story with objectivism, but he and I had the opportunity to get together recently, about a month ago in Phoenix, and I was just so blown away by his breadth and depth of knowledge and experience on a range of topics, but specifically with regards to health reform and opioids. So we're going to get to that. Jeffrey, welcome again. Thank you for joining us.
Well, it's great to be here. Thank you.
So I just wanted to start off with a story that you shared with me over pancakes in Phoenix about your practice at the hospital and your surprising discovery that you had COVID unbeknownst to you. So just share a little bit of that personal story.
Well, sure. Well, I still practice as a general surgeon in addition to working at the CATO Institute. And the hospital, this is sometime in late May, because I've been going in and out of the hospital, taking care of patients or seeing them in my office. So the hospital gave antibody tests to all of the medical staff once the antibody test, the good one by Abbott Labs, became available. And I'd never had symptoms. About 24 hours later, I get a phone call from the medical director of the hospital. Asked me, have you had a fever lately? No. Feel extremely tired or aches and pain? No. Turns out that I was positive for IgG, which is the antibody that your body produces at the tail end of the infection, when this is when you've already over the infection and you have immunity. So I was another one of the many cases that we now know, we didn't know as much in the beginning, who was asymptomatic. Now, in January, February, and March, I'd been traveling a lot in airports, so I assume that's where I contracted the virus, but I never felt it. Then, on top of that, as soon as I learned of that, I had my wife run down there and get the same test. She tested negative, which came as a surprise. But then I started digging into the literature, and actually there's a lot of research now coming from Germany, China, that suggests that people who are asymptomatic, even though they have the virus during the early stages of their infection, of course it's hard to know when they're infected if they don't have symptoms, but those who are asymptomatic actually have a much lower incidence of spreading to their contacts in their household. One study in University of Guangzhou, where they tested people who were positive and either had mild symptoms or no symptoms, and they told them to go quarantine with their family because the hospitals were overloaded, plus they weren't sick enough to be in the hospital. And then they followed up on them, and they found that in most cases, nobody else in that household came down with it. So kind of intuitively, it makes a little bit of sense anyway, because if you're not symptomatic, then you're not, you're not coughing, you're not sneezing, doing those kind of things. But still, the evidence is that you still have a lot of viruses in your mucous membranes. But now, again, we know a lot more now than we did 6-8 months ago. So there's, again, a lot of this is all, inconclusive, but, for those people who know something about immunology, you have two types of lymphocytes, the B cells, which make the antibodies, and the T cells, which do a whole host of things, including just go after the bad guy by themselves. Plus, they have a certain degree of memory and stimulate the B cells to make more antibodies once that original virus returns. So now one of the theories that has a lot of plausibility to it that's being discussed is that the reason why up to 30 to 40% of people don't get any symptoms, and the overwhelming majority of people get, like 90% of people get mild to moderate symptoms, is because the COVID-19 is a coronavirus, and there are many common colds that are coronaviruses, and while they're not the same, they're still in the same family. So we think that exposure to prior coronaviruses has conferred a certain amount of memory to your T cells. And so then when the COVID-19 enters your body, this isn't the same coronavirus the T cells recognize, but they recognize enough of it that they, to a degree, go after it. And that's why we think that you don't get as sick. And that may also be why so many young children, grade school age children, don't seem to get very sick at all. And that's probably because they're always giving each other colds all the time. So, I mean, this is not proven yet, but this is a very plausible theory that's being considered. And it kind of fits with me. And then after I shared I actually blogged about it at the CATO blog, and I got a lot of communications from a lot of people saying, I have the same story. So I just thought that was interesting. It helped kind of stimulated me to learn more about how this virus works.
Well, and one of the people who responded to you that said he had the same story, of course, was another Atlas Society supporter and a fellow doctor, Senator Rand Paul, right?
Right. Well, his chief of staff, yeah, spoke to me about, yeah. He had a similar kind of story. He was asymptomatic. He thought when this thing broke out, with my history of my lung injury, I might be at greater risk. Maybe I ought to get tested. And to his surprise, he was positive, and he was criticized, but he really didn't think he had it. And then he quarantined with his family for 14 days, and nobody in his household ever tested positive. Same kind of thing. That's not an unusual story. So it's important for people to kind of put this in perspective, because there's a tendency for, when the press reports on this, it's, if it bleeds, it leads. So you like to spend a whole lot of time talking about the bad cases, and it can lead a lot of people to believe that, it can lead a lot of people not to put things in their proper perspective. I'm not trying to say, like some people say, oh, this is just like the flu. It's not. It actually is more contagious and more deadly than the flu. But on the other hand, forgivingly, it's actually easier on young people than the flu. And so I just think that, when you're making decisions about risks you're willing to take and trade-offs that we're willing to ask people to make, we should not focus on just the bad outcomes, which it looks like it's going to be roughly 0.4% fatality rate, which is still about 3 times the fatality rate of the common flu. On the other hand, it's almost all skewed towards the very older population, mostly with a lot of pre-existing medical vulnerabilities, and spares the younger. So the younger people, like the school-age kids, are actually at more risk of getting something serious from the common influenza than they are from this.
It's fascinating. Well, what you talked about in terms of perspective really resonates. I like to say you can't be objective unless you have perspective. And clearly we're continuing to learn a lot about this virus, how it spreads, and what the impact is, including, major influences in terms of morbidity, such as obesity, which I think is a really important thing to keep in mind. But, in terms of your perspective, having watched also this with how the government has handled it, how do you see it as a doctor? What are some of the problems with how the government at various levels have handled this pandemic?
Well, it's a couple of things. Number one, this is the people who are libertarians. This is a classic case of government failure on so many different levels, federal, even global, state, local level. There's lots of government failure all the way down. I think we could all agree that a legitimate function of the government is to operate in a public health crisis, to prevent. It's sort of like getting invaded by a foreign army. So that's a legitimate function of the government. Well, it failed in its legitimate functions on multiple levels. So first of all, one of its important functions is to inform the public about it, and it's whether or not it's serious and what steps they can take to protect themselves. Well, for a while there, it was telling us it's nothing to worry about. Then when it became apparent that actually this is a serious infection, it could be a pandemic, that's when they failed first on the information level, and then they asked everybody who they've been saying for several weeks, this is nothing to worry about. All of a sudden they said, forget about that. This is something to worry about. Everybody listen up. Then you talk about the testing. So for example, as soon as the tests came out, first of all, when China finally admitted that they had a problem, they isolated the genome of the virus and shared it with the World Health Organization, which then shared it with the world, which is the way things are done. And at that moment, a company in Germany, a private biotech company, developed a test, and the German government said, go ahead and start using it. And the World Health Organization had purchased a bunch of these tests and started distributing it to countries, particularly poor or less developed countries that didn't have the means to develop their own tests. South Korea, which had a bad experience back in 2009 with MERS, they learned from that mistake, and they said they actually passed a law saying next time there's a public health emergency, private sector, go ahead and develop tests. Don't wait for us to approve it. Just inform us, keep us in a loop. We'll monitor it, but get it out there. And then after the fact, we'll kind of keep an eye on things. Well, that's not how it worked in our country. So here we're supposed to be the beacon of free enterprise to the rest of the world. And we kind of behaved the way I would have expected, East Germany to behave. So the World Health Organization gave the genome to the FDA, which then gave it to the CDC. And the CDC was told by the FDA has to approve all tests in this country. And the FDA basically gave emergency authorization to the CDC to develop a test, and then sent out word to all other labs in this country, both public and private, that if you are interested in developing a test, you first have to have it run it by the CDC and see how it measures up to the test they're developing. And it kind of sent the message that the CDC's got this. And so all of the other labs that would have been considering it didn't do anything because it would have to go through CDC first before the FDA will even consider giving approval. So it basically had a government monopoly developing a test. And then in late February, when the test was supposed to get out there, we needed it out there in a lot of places, so we knew who has it, who we need to set. Because when you're trying to manage an epidemic, you want to separate the contagious people from the non-contagious people. Well, how are you going to know that without testing? So it turns out they had underestimated how many tests they needed. This is a government monopoly. They only sent it out to a couple of centers, and then when they started using it, it didn't work. So it's like, not only did we follow the East German model in developing and approving the test, but our test was like the Trabant, it worked just as well. So finally, almost, playing catch up, the FDA at the end of February, beginning of March, started telling a lot of private sector and, public labs, university labs, sort of what South Korea did. It said, you have our permission to get started. Go ahead, don't wait for us, just get going with it and keep us in the loop. And then finally in mid-March, as we were still playing catch up, they told governors, listen, you governors, your states, you could decide what tests you want to allow in your states as well. You don't have to wait for it to be an FDA approved test. So that way, healthcare practitioners could either use a test that was given emergency authorization by the FDA or was approved by their state. You got those two options. And that's when things started to really catch up. But those are things, of course, that we could look in hindsight. These should have been in effect way before then. So there's a lot we could learn from this as to how to reform policies going forward, particularly when it comes to FDA regulation and approval of tests and drugs. So that's just on that level. Then on a local level, we had lots of problems. For example, one of the biggest obstacles is medical licensing laws. In fact, all occupational licensing laws are obstacles to allow new entrants into a field. As I'm sure this audience knows, the biggest advocates of licensing laws are the people in the business, the incumbents. And of course, they try to sell the public on, you need to have restrictions on who can do what we do because other people may not be as safe as we are. So we're only thinking of you. And so occupational licensing laws on all fields limit new entrants, restrict competition, and usually the licensing boards eventually get captured by the licensees who have a lot of say over what the new rules are going to be for new entrants. Well, the same is the case with medical licensing laws. So here, everybody's asked to confine to their homes because we're afraid people are going to catch the virus, and you can't get to your doctor. And in every single state, telemedicine is a technology. Actually, it's not new. It's, this technology has been around, is being used in other sectors for years, but it's been stunted in healthcare because of licensing laws. So in every state, including my own, I can't practice telemedicine across state lines. So I can only deliver telemedicine to patients within my own state. Or if I want to deliver telemedicine to patients in another state, I got to get a license to practice in that state as well. So that made it very difficult, particularly for people living in remote areas, to get healthcare. So all the governors suspended that as an emergency, that, we're going to allow you to practice telemedicine across state line. And the federal government said, and Medicare will pay for it, because Medicare wasn't even paying for the delivery of telemedicine. That's one thing. Then lots of states had shortages of healthcare practitioners on all levels, nurses, doctors, all sorts of healthcare practitioners because of occupational licensing laws. So in many states, the governor said, if you have a license in any other state, come on over. Don't worry about that you don't have a license here. We need you. We're temporarily suspending those requirements. Come over, please help our patients. And in some cases, they were even saying this to foreign doctors. I had a conference on this last month at the CATO Institute. Many people may not be aware of this, but you could be an experienced medical specialist who graduated a reputable medical school in, let's say, Syria, and you've been practicing for 10 years and rendering excellent care, and you want to come to America because you don't want to live in Syria. Well, states in the United States would require that you repeat the entire postgraduate training that you had to do to become what you are. So, for example, a general surgeon has to do 5 years of, we call it nowadays postgraduate training. Old school term is residency. So you could have been a surgeon for 10 years already. You did your residency 10 years ago. Now, if you want to come and practice in the United States, to get a license to practice in the United States, you got to do a residency all over again. And you may not have you may not, first of all, want to go through that, demoralizing experience. Plus you have maybe a family support. You can't go through this again. So you have lots of doctors who are able to emigrate to this country, and they're like driving Ubers or waiting tables or working in restaurants. What they did, many states said, if you're a healthcare practitioner who fits that description, we're temporarily suspending those requirements. Come over here, help our patients. So what I'm concerned about is most of these emergency measures, what they're basically doing is they're tacitly admitting that all of these regulations that have been in place have stood in the way of the rapid and nimble response to a healthcare crisis. And if these are important to get out of the way when we have a crisis, they shouldn't be important to get away all the time, because not just wait for the next crisis, but they should tell us that in general, these things are getting in the way of delivering healthcare to people who want it and where it's needed. Other state laws, there's a thing called certificate of need laws, where this is in about 35 states still, where if you want to add, depending on the state, let's say you want to add a wing onto the hospital or add some more beds, or in some states, if you just want to add another MRI machine or add a new section to your clinic. You have to apply to a committee, a state committee, that has to decide there is a need for this. And usually the committee is either stocked with your competitors or at least influenced by your competitors. So an analogy would be, let's say we had a certificate of need law for restaurants, and you got this really neat idea for a brand new concept in cuisine and dining, and you want to open up a restaurant. Let's say it's, Asian fusion. And so first you have to apply to the Restaurant Certificate of Need Board. And the Restaurant Certificate of Need Board, which is, staffed by many restaurant owners, looks over your proposal and says, well, actually, we got enough Asian fusion restaurants, so we're going to have to say no. That's what goes on right now in 35 states. So when, in my state, we're one of the states in Arizona that doesn't have that, neither does California. So when our hospital administrators in Arizona had already gotten wind that there could be a bad epidemic heading our way, they already started taking steps. They added beds to parts of the hospital that are ordinarily stocked with beds. You can convert the cafeteria into a ward, for example, if you need to, things like that. They didn't have to get permission from some bureaucratic committee. They just did it. But in other states, governors had to temporarily suspend these laws to allow these hospitals and clinics to make these changes. And some states didn't. I'm told that Kentucky still kept the certificate of need laws in place. So these are just a few examples. So what we basically, there was basically a whole cascade of problems that this public health emergency revealed to the public. So, if you're a glass half full kind of person like I am, I see in this an opportunity actually to be able to say, let's look at all the lessons we can learn from this. Look at all the things we should be revisiting, because if we don't, we're going to go back to the status quo ante, and it's just going to happen again. So there's a great opportunity for a whole bunch of things like FDA reform, eliminating licensing, eliminating certificate of need laws. I can go on and on about different kind of reforms about that. But there's a lot of opportunities for reform. On the other hand, there's another thing that, as a libertarian, I fear, because we all know about the Ratchet Effect. And if anybody hasn't read Robert Higgs' book, Crisis on Leviathan, I highly recommend it because it's a great documentation of the Ratchet Effect in action historically. But basically, it's as Randolph Bourne said, war is the health of the state. And this is sort of an equivalent to war. Every time there's a crisis, power accrues to the state, and some of it's necessary in order to prosecute, to deal with a crisis. And people are asked to surrender a certain amount of their liberties. But when the crisis passes, the power of the state never recedes completely to the pre-crisis level. And the people have gotten just a little more comfortable having given up their liberties. And that's the glass half empty side of this thing, the other side of the coin that I worry about. I see people are so driven by fear that they're allowing, in some states, some governors seem to have, there's no logic behind some of the edicts that they're passing, and people are putting up with it because they're afraid. It's anybody who read Atlas Shrugged knows there's fear could drive people to give up a lot of freedom in hopes of getting security, and then they have neither.
Well, that's so true. And of course, Atlas Shrugged is a classic tale of crony capitalism and its impact on progress, on individual life, on liberty. You talked about this crisis, the crisis of dealing with the virus, but and I also wanted to just, for people who'd like to hear more about Dr. Singer's thoughts on occupational licensing, he is going to be moderating a CATO online event on September 14th. So, so check that out, whatever we can do to help promote it. We love our partnership with CATO. And but you've also written extensively prior to all of this on. I don't even know if the crisis is the best way to describe it, because as you say, when you can trigger fear, you can grab power. And so when people talk about the opioid crisis, if that is even the correct way to talk about it, what has happened with that, with opioid use, opioid overdoses during this epidemic, and what's the solution?
Yeah.
And
Well,
by the way, reminder, everybody, do ask your questions because we are going to get to them real shortly.
Well, first of all, I don't like to call it an opioid crisis. I actually call it a prohibition crisis. That's what I call it. And not only that, but the term opioid is often, misleading. A lot of people, when they hear the word opioid, they're thinking of a prescription painkiller, like, Percocet or something like that. When actually, medically speaking, opioid is just a whole category of drugs, just like coronavirus is a whole class of viruses. So, for example, heroin is an opioid. Fentanyl is an opioid. There are a lot of opioids. So what really has kind of frustrated me is back in the early part of this century, the policymakers and the press, because, I think it was Mencken who said that for every problem, there's a real simple explanation and solution, both of which are wrong. So they like simple explanations. That's a paraphrase. Anyway, so they locked into this idea that because doctors have been prescribing more painkillers in recent years than ever before, and in the early part of the 2000s, a lot of the people who were using what's called diverted prescription painkillers, that it means they've been diverted into the black market, and they've been using that either recreationally or whatever, that therefore the cause of the overdose crisis, because there's been an increasing overdose rate for decades, and suddenly kind of hit critical mass. And the cause of the overdose crisis is these doctors who were conned by the evil pharmaceutical companies into overprescribing pain medicine for their patients. And now they turned all their patients into drug addicts. And that narrative still won't go away, despite whatever the evidence shows. So that's what the evidence showed. I mean, that's what the narrative said. Well, in fact, in the early part of about the 1970s, 1980s, when I was just starting in practice, we clearly were under-medicating people for pain. And there have been numerous articles in the medical literature pointing that out. And I could attest to it because I was in medical school at the height of President Nixon's war on drugs and this whole drugs are bad kind of thing. And we doctors were indoctrinated into under-prescribing opioid like morphine, Demerol, Vicodin, whatever, because we can get people hooked. And the patients were being told the same thing. I remember making rounds on my patients in the early 80s, post-surgical patients, and they're clearly in pain, sweaty, hyperventilating. And I say, I told the nurse to bring you some morphine. All you have to do is ring the buzzer and you'll get morphine because that's what it's there for. No, I don't want to get addicted. And so you had it on both sides of the bed. The doctor and the patient were afraid that if you take an opioid for pain, you'll get addicted. Well, it became apparent by the early 90s that was wrong. And many studies had shown that when used in a medical setting, the addiction rate is actually extremely low, including even recent reports by Dr. Norovako, the head of the National Institute on Drug Abuse in the New England Journal of Medicine just a few years ago, pointing out that it's extremely rare. And eventually, we doctors were urged by anything from the NIH to the HHS to you name it, to start loosening up and taking care of your patient's pain. And the patients were told to overcome their fear of getting addicted. So by the late 90s, early 2000s, we were prescribing more than ever, and patients were accepting it. So, but research has shown that the overdose rate from the non-medical use of either licit or illicit drugs has been on a steady exponential increase since at least the late 1970s. University of Pittsburgh published a great study on this back in 2018, and you can see just a straight curve. The only thing that has changed over the decades is which particular drug is predominating among the causes of the overdoses. So in the 70s and early and 80s, it was heroin. Then it became cocaine and stimulants. Then in the 90s, it was Vicodin. Then in the early O's, it was OxyContin, which is just a concentrated oxycodone, which is Percocet. But then around 2010, it switched to heroin, and then it became heroin and fentanyl. And now it's like 90% heroin and fentanyl, 10% is diverted prescription opioids. And guess what? Meth is back. Remember back in 2005 when Congress fixed the meth crisis? Remember those TV commercials with showing people with bad teeth? So they passed a law making those of us who get good relief from Sudafed, which is a great decongestant. Now we had to show your driver's license, and you got to get it from a pharmacist, and you're only allowed a certain amount a month. In 2 states, Oregon and Mississippi, they made a prescription for Sudafed. So, and then the SWAT team started going after all of these meth labs that were all over in all different neighborhoods. So that meth was about the only drug that the cartels from Mexico weren't involved in smuggling into the U.S. because there were so many homegrown meth labs that it was just no market for it. But this opened up the market. So within a year, the meth started coming in from Mexico. And then when Mexico was pressed by the U.S. to make Sudafed behind the counter also, well, now you have these sophisticated cartels involved in it. So they quickly found out, as anybody who's ever seen Breaking Bad knows, you could make meth much more efficiently out of phenyl-2-propanone, or P2P. So they started switching to that. And now, in the latest numbers from the CDC, the most recent numbers, methamphetamine is up 10% over last year, meth-related deaths. And in fact, it's rising, it's at all-time historic levels, meth-related deaths, and it's rising faster than deaths from fentanyl or anything else. Some people use fentanyl to even out the meth, and some people use meth to even out the fentanyl. So some people like to combine the two. In any case, meanwhile, like a broken record, the policymakers keep passing these laws telling doctors how many opioids they can prescribe for patients based upon what their problem is, what the dose they can prescribe. I don't know how many opioids my post-surgical patient is going to need. I don't know what dose it's going to take to control that person's pain because everybody's different. Some people don't need much of anything. Some people need more than others. But somehow the politicians in the government, they can figure out just how much. And the Drug Enforcement Administration is each year now, talk about central planning, talk about East Germany, their job is to figure out how many opioids of all categories, from intravenous morphine to intravenous fentanyl to Vicodin pills, how many need to be manufactured in the coming year to control the pain of 330 million Americans. They presume to know how many, and then we develop shortages in the hospitals because the quotas were too small. So this is what's going on now, and at this very minute, there's a bill that was introduced in the House of Representatives to further crack down on doctors prescribing pain pills to their patients. So we got people now who are we're back to the 60s and 70s, people getting under-medicated for their pain. A lot of them in desperation are turning to the black market where they're getting counterfeit Percocet or oxycodone made out of smuggled in fentanyl. By the way, almost all the fentanyl that you hear about in the overdose death statistics is illicit fentanyl. The fentanyl that's made by pharmaceutical manufacturers is almost always, injectable form. Sometimes it's in a lozenge form or a little thing you put inside the inside of your cheek, like those kind of things that Listerine makes for your tongue, for your breath, that kind of thing. Or another popular way is skin patches, where it gets absorbed slowly through your skin over about 3 days. But the kind of fentanyl that's being used is mixed in with heroin or cocaine. It's a powder that's made in clandestine labs in Mexico, mainly in Asia and China. It's made very easily, and as soon as we press the Chinese government to tell these labs to stop making fentanyl, they say, okay, so then we'll make sufentanil. Or there's so many different carfentanil, there are different analogs. It's just a matter of adding another little, carbon molecule. So that's what's happening. So fentanyl is being smuggled into the United States, sometimes in the mail, and UPS, FedEx. A lot of dealers have these pill presses, and they're pressing fentanyl into counterfeit prescription pain pills and then selling them to people. In fact, that's how Prince died. The actor, the artist Prince. He liked to use
Or artist
Vicodin.
formerly known as Prince.
Formerly known, it's actually the formerly alive artist,
Right.
formerly known as Prince. So he liked to use Vicodin recreationally. That was his drug of choice. So he, his dealer went and got him some Vicodin, but his dealer apparently didn't know that he was buying fentanyl made to look like Vicodin, and the coroner's report showed it was fentanyl that killed him. And by the way, he never once went to a doctor for a prescription. The data shows that almost, according to the National Survey on Drug Use and Health, 75% of people who use diverted prescription pain pills non-medically never go to a doctor. They get it from a dealer or a friend or something like that. So now this pandemic has made things even worse because there are chronic pain patients who are already being cut off by their doctors, who are afraid of getting arrested by the DEA for overprescribing, which means not prescribing according to the way the policemen think they should be prescribing to their patients in pain. And so they're in fear cutting patients off. And now these patients can't even get into a doctor because these doctors' offices are closed. And then you have people who actually truly have addiction, and they're having more and more difficult time getting into harm reduction programs. The needle exchange programs that are preventing overdoses by handing out naloxone, the antidote, and preventing the spread of HIV. Well, they're not around because everybody's quarantined. And it's more difficult for the methadone programs and the other what's called medication-assisted treatment programs to function. And then another thing is when you're trying to recover from addiction, one of the keys is most people with addiction have a sense of loss of connectedness. They're very kind of alienated and isolated. And the treatment involves getting a new sense of connection because it's a behavioral disorder. And the last thing you need when you're trying to establish a feeling of connectedness with a person who's trying to overcome addiction is I quarantine them in isolation for 6 months. Doesn't usually help.
That's a really good point. Well, we were talking earlier, I wanted to get to a couple of these questions from the audience.
Okay.
We were talking about different populations with regards to COVID. Roy Miller wants to know when you're talking about legalizing drugs, what age limits are there? Should there be age limits?
Well, I see no problem. I'm talking about adults,
Right.
Just like alcohol is and should be legal for adults, and tobacco is and should be legal for adults. I'm not talking about legalizing necessarily any drugs for children. Although, the children right now could go into a store and buy Tylenol over the counter or ibuprofen over the counter. But I'm not talking about these drugs that have a dangerous potential being available to minors. I'm talking about adults. That's what I'm saying here. But as far as I'm concerned, any kind of drug at that point, because an adult has a right to decide what to put into their body. And one of our most fundamental rights is the right to self-medicate. I don't think that I should have to ask permission from another autonomous adult before I put something into my body, even if I'm making a mistake. That'll be, my decision, and I'll face the consequences of my mistake. But I shouldn't have to ask anybody else if it's okay with them.
So Jeff Minder, hey Jeff, I'm so glad you were able to join us. He has a private company that were the first in the world to train dogs to find the COVID-19 virus. Have you heard anything about these testing capabilities using canines?
I've heard about it in press reports, but I really don't know enough about it to really comment. I mean, it makes sense to me that when people have a certain kind of illnesses, sometimes, dogs have such a sensitive sense of smell, and people with certain kind of illnesses, to dogs, they may be able to pick up some, aroma from them. Humans often don't notice that. Although in certain diseases, like people in kidney failure or liver failure, they actually have an aroma that we doctors can notice on them. But, our sense of smell is nothing like a dog. So their aroma's got to be pretty pungent before we notice it.
Fascinating. So we have another question, of course. Who is John Galt? So we would love to hear about your fascinating origin story with the ideas of Ayn Rand. Tell us about how you first came across her and your intellectual journey with those ideas.
Well, I was actually an undergraduate college student at the time in the 60s. Actually, I started college in 1969, early 70s, and this was the height of a lot of campus activity, campus unrest, and I grew up in a liberal democratic household, very pro labor union, blue collar.
Same
My dad,
here.
my dad was a taxi driver, and my mom worked as a legal secretary, and they actually were. My whole family was always having animated discussions over politics. So I grew up kind of in an atmosphere where I thought, these ideas mattered, and you get excited about it. You have arguments over it. So that was sort of kind of drilled into me, I guess, by osmosis. And then when I started college, I thought to myself, well, I really never had a chance to think about how I think about these things. I just was sort of parroting what I was kind of growing up with. And most of what I was growing up with was sort of the majority view when I entered college. And so I just decided, the part of me was, I guess, I must admit, it was sort of my own rebelliousness too. I decided I'm not going to let anybody tell me how I should think. I'm going to decide for myself how I should think. So sort of I intentionally started looking at what the opposing point of view had to say, just because I never gave that view a chance. And so I started looking at, this was, remember, early 70s. I started looking at conservative literature, which was the opposite of everything I was seeing. And contrary to what I had been led to believe, the conservatives, at least rhetorically, said they believed in limited government, individual liberty. And to me, that's, of course, who's not for individual liberty and limited government? That was like, to me, a no-brainer. But then as I started reading a lot of conservative literature, I was starting to have problems, because another thing about me, and probably, I imagine this is what makes every libertarian would say this, I'm a real stickler for consistency. And I was noticing inconsistencies. I'd walk around with a copy of either National Review or Human Events, which were about the only two publications back then that were available, that were intellectual and sort of on the right. And one classmate of mine, I was pre-med in my microbiology class, saw what I was reading, and he came over to me, and I guess he saw there was somebody who also didn't think like everybody else. And he said, "Have you ever read Atlas Shrugged?" And I said, "No, I probably will someday," because I saw how big the book was, and I had it was the same size as my organic chemistry textbook, and 1,000-page book is enough for me. So, but I did make a little concession. I read Anthem because that was a quick read over a weekend, and I enjoyed it. So anyway, one day I was actually in an argument. Did I tell you this, by the way? I was in an argument.
You told me, but you didn't tell. I wanted you to tell.
Okay, I didn't remember if I told you. I was in an argument with some members of the SDS, Students for Democratic Society. I don't think they're in existence anymore, but they were one of the more, I guess they were the early 70s version of Antifa, okay? And they were actually they weren't violent though. And we were having an argument over capitalism versus socialism, which does the most good for the most people, or something like that, out on the quadrangle. And it was debate. And it was actually, friendly, and a crowd was gathering around us. And in the crowd was this classmate of mine. And the next class I had to go to in about 15 minutes was the microbiology class. Anyway, he asked me a question about, well, in your ideal society, well, who would take care of the poor people? And I believe it or not, I wasn't ready for that question. And I quickly finagled an answer. And while I'm giving him the answer, I'm not satisfied that that's a real well thought out answer. I see a lot of holes in it. But fortunately, he wasn't as much of a stickler for logic and consistency as I was. So he kind of accepted my response. I thought I got away with it. And then we sort of all had, it kind of broke up because we all had to get to the next class. And the member of the crowd who was the Atlas Shrugged proponent, he made eye contact with me, and we walked together to the building where the microbiology class was, and he said, you know, you're never going to be able to defend capitalism properly until you can defend it as a moral system. It's not just an economic system. You really should read Atlas Shrugged. And that sort of convinced me. So I ended up reading Atlas Shrugged, and that's a very common story. My generation, that a lot of times was their entry into libertarianism. Now, I'm, I guess, a hippie of the left, because that's what Ayn Rand thought of libertarianism.
Hippie, you're a hippie of the left.
Yeah, so that was my introduction, and then I went to med school, and then did my residency, and I kept subscribing to different publications. I kept, because that was always my other passion, but I really didn't have a lot of time for anything except, you know, buckling down and learning. And then I had to start a practice. I started a solo practice all by myself. So for several years, it was I'd find time to read political philosophy and public policy, and I started subscribing to, you know, Reason magazine, and I became a donor to the CATO Institute. And it wasn't until the 90s when my practice had really become mature and established. I had a couple of partners. We gave ourselves personal days, and being the unusual person I was, on my personal day, instead of using that day to play golf and get a haircut and stuff like that, like my two partners did, I used those days to write and get involved in ballot propositions and become sort of an activist. And that's how I got into this. And that grew and grew and grew. And I must say that I'm still very much influenced by objectivism, but I've also become more of an independent thinker over the years. So I know there are some areas where I would part ways with Ayn Rand, particularly on more derivative things. I still think that her discussion of ethics and the nature of rights, nature of man's rights, basically, you know, segue into political theory. That I'm 100% on board with that. That makes the most sense to me. On some areas like foreign policy, aesthetics, we part ways. And I've been introduced, and I guess I might say also, I'm still an atheist, but I'm much more tolerant than I used to be, because working with life and death situations, people in all walks of life, and being a libertarian with libertarian sensibilities, you know, my attitude is, you know, whatever works for you, that's, you know, that's fine. I'm glad it's working for you. It doesn't work for me. I don't need that for me. But, you know, I'm a live and let live kind of guy.
Well, we will claim you as an open objectivist, in addition to being a libertarian, as someone who does understand, I think, the unique resources, intellectual resources, persuasive resources that Ayn Rand brings to the debate about liberty. So getting back, though, to what we were talking earlier with the pandemic, and also the psychological factor of the fear, Vicki wants to know, in your practice, do you come across patients who have an outsized, you know, the fear that they have about their personal risk and exposure to coronavirus? Do you come across that, and how do you handle it? Do you have ways of coping with them, or you're just like, well, I'm here to give you a operation and that's what I'm going to do?
Well, it's interesting because the way I experience it is in people not coming. So, wow. Yeah. So the first thing that happened, and I've written about this too. So again, I actually want to talk about this. So then some governors in some states, like in New York and California and Michigan, they just went, you know, whole hog and basically put people under home arrest and give the statewide equivalent of martial law. Some had curfews, all that kind of thing. And then that started almost a competition among governors. Each one didn't want to be perceived or reported in the press as being sort of too carefree, not concerned about the welfare of their state's residents. So they had to do something. So the governor of my state in the beginning, I think the end of March, imposed a lockdown. And the virus really hadn't made its way to Arizona yet. So there were very few cases. And he put a 6-week ban on all elective procedures. Now, a lot of people think elective means like frivolous, like, you know, cosmetic surgery or something. No, elective just means you could schedule it. It doesn't have to be done this second, as opposed to emergency, but it doesn't mean it's not necessary. So basically, surgical practices were locked down. The only thing we surgeons can do is take care of people who are showing up in emergency rooms with emergencies like a perforated gallbladder or ulcer or something. And even then, what we were seeing in the emergency rooms were people coming in much worse shape than we usually see them. So we've seen people come in with a ruptured appendix that ruptured 5 days ago, and they were on death's doorstep because they were afraid to go to the emergency room where they might catch the virus. Instead, they were going to die from ruptured appendix, or people who were letting their heart failure go until it was really bad. So that was happening. So for the first 6 weeks, we were getting, there was nothing going on. Then the governor, when it was obvious that there were many cases in Arizona, and hospitals were at 40% capacity. They usually like to be about 75, 80% capacity because that's what kind of keeps them solvent. So they were at 40% capacity. They were laying off nurses and other staff and doctors if they were working for hospitals. So he lifted the ban on elective surgery. Then as people, and then he started relaxing all of the restrictions. And then in June, the virus kind of made its way to Arizona. And then, of course, I could have told him, because I learned this before I went to medical school. I learned this when I was a biology major in college, that it's not like the virus goes away if you hide from it. It's still there. In fact, some of these people who are not getting their children vaccinated against measles, we're seeing measles cases come back after 20 years of no measles cases. It's not like the virus goes away. So when you take a bunch of healthy people and insulate them so they can't catch it, are you surprised that when they come out, they catch it? Of course. You should be isolating the sick and contagious people, not the healthy people. So that's what we did. We isolated, for the first time in medical history, isolated healthy people. So cases started going up, but this time the governor didn't make the same mistake. He let happen what has been always the case, because every couple of years the CDC warns us, we're expecting a horrible flu season this year, you know, be on alert. And the hospitals, different hospitals have different patient populations and different realities that they're having to work with, and they work with the medical staff. So the hospitals will tell us surgeons, look, we're getting overloaded with flu cases right now. Before you bring in your next elective surgery, could you talk to us? Because we may not have room. We may ask you to hold off for a couple of weeks. And each hospital and each community, on a case-by-case, you know, individual basis based on local knowledge, works it out. So that's what the governor allowed to happen this time. So sure enough, my group, we're 11 surgeons now. It's grown. And we use 2 hospital systems. One is 5 beds. One has 5 hospitals. One has 7. The 7 hospital system never reached a level where they asked us to hold off on elective surgery. But the 5 hospital system had a lot of major critical care centers, and they got inundated. And for a 2-week stretch there in mid-July, they asked us to not schedule any more elective procedures, and they'll let us know. And then after 2 weeks, they said, okay, it's calming down now, you can start bringing them in again. That's the way it should have been handled in the first place. Now, so getting back to the original question, once we were allowed to start doing elective procedures, we started calling all these patients who we had seen already, who were on hold. They needed their gallbladders removed or whatever. And we called them and said, okay, the coast is clear. You can come on in. We can talk about scheduling your procedure. And a lot of them would say, no, I'm not going anywhere. I'm afraid I'm going to catch it. So, but the people who arrived in our office, it's sort of self-selected. The people that we see in our office are people who are not, you know, overcome by fear. So they come into the office and schedule a surgery. They weren't worried about scheduling the surgery. So that was one problem. And we're still seeing it even now. For the time of year, business is, in all kind of medical practices, slower than usual because a lot of people are still afraid to go to the doctor's office. And you probably have read, it was reaching a real serious level where a lot of parents were afraid to bring their young children in for their scheduled immunizations And some, young children, there's some critical periods where they need certain immunizations where it could have serious public health consequences not to get them. And the parents were afraid to bring them into the pediatrician's office. And the pediatricians were making arrangements. They were doing things like coming down to the car and giving your kid a vaccination in the car, in the parking lot. They were willing to make all these kind of accommodations because they wanted these kids to get immunized. But a lot of parents, the immunizations were way down. And still at this point, there are a lot of people showing up in the emergency room with much more advanced conditions that had they gone to their doctors sooner, they may not have been emergencies. So that's the kind of thing we deal with. We deal with people who are afraid to get help because they're not putting things in perspective, not realizing that there's a 95% chance that if you contract the virus, you won't be sick enough to be in the hospital. 95% chance. And if you're a 40-year-old healthy person, you shouldn't let the risk of catching the COVID-19 stop you from getting a necessary cancer screening procedure, for example. So, and we're seeing delays now in diagnoses of things that is affecting the prognosis.
Wow. Larry Borland. Hey, Larry. So good to see you. Also, a longtime Atlas Society supporter. Has a few observations, including, I'll take just one quick one because we're coming up on the top of the hour, about SDS, not true for some of the leaders who were violent. And maybe
I'll agree to that. I mean, I think there were bombings of certain police stations and things like that. But yeah, that's true. It's just, let's put it this way. The SDS students on campus weren't just kind of, setting fires in downtown randomly and,
right.
Smashing in, looting window stores and things like that. It wasn't like today. I just think Antifa is a more virulent strain, let's say.
It is a nihilistic, and we have many videos on this, as you all know, talking about socialism as a SDT, a socially transmitted disease, and that is something that the Atlas Society is seeking to inoculate young minds. It's why we have our graphic novel, it's why we have our animated videos, it's why we have our pocket guides, and also why we have these forums which allow for a little bit of a deeper dive into some of these subjects with people that are part of our community. I'd also like to remind all of you who are either new to the Atlas Society, are supporting us at a certain level, or yet to support us, that our chairman Jay LaPere, is matching all new and all increased donations. So please take an opportunity, if you're enjoying this content, if you think it's important for us to do more and share this with more people, to join Dr. Singer and join so many of the people that are on the call, and supporting what we're doing. I really appreciate it. Happy birthday, Michael Newberry, who was on a recent one of our lives, and thank you so much, Jeffrey. It's wonderful to see you. You are just on fire in terms of the work that you are doing right now, and it was a real privilege to be able to have you join us and share some of your thoughts with our audience.
Well, thank you very much. It was a pleasure.
All right, take care. I'll see you soon.
Bye-bye.